This lecture concerns the regulation of respiration, and the first point to be considered is the structure of the brainstem respiratory center. This center is located in medulla oblongata and pons. The center is composed of many groups of neurons that have numerous complex interconnections. Generally, they all belong to the reticular formation of the brainstem. Reticular formation is characterized by many interconnections that form the neuronal networks. And the respiratory nuclei located within the reticular formation of medulla are. Actually, there are many subgroups of neurons, but we can combine them into two large groups. The dorsal respiratory group that consists of the inspiratory neurons. These neurons are the main in the efferent control of respiration. Their function is to stimulate the inspiration, and the duration and strength of the stimulation determines the level of the inspiration as a whole. The ventral respiratory group of neurons consists of both inspiratory and expiratory neurons. The inspiratory neurons function together with the function of the dorsal respiratory group, and expiratory neurons, in case of the quiet resting respiration, are not active, and they become active only when respiration becomes more intensive. The parts of the respiratory center located in the pons. There are two other centers. First, the pneumotaxic center, located in the upper pons. It inhibits inspiration, and therefore it regulates the volume and rate of breathing, because when it inhibits earlier, the inspiration becomes shorter and not as deep as before, and so it changes both volume and rate of breathing by inhibition of inspiration. The other center is called apneustic center. It's located in the lower pons. It stimulates inspiration, thus opposing the pneumotaxic center action, and makes inspiration prolonged and therefore deeper. Generally, this type of breathing with a deep prolonged inspiration is called apneusis. Let's observe all these parts of the center together on the picture. First, you can see the sagittal cross-section of the brain. Now, let's separate the brainstem and enlarge this. Now you can see medulla lower located and pons above. First, let's start from medullary centers. And of course, it's the dorsal respiratory group center located exactly dorsally, which contains the neurons that generate the rhythm, that produce the output for the controlling of respiration. More ventrally located is the ventral respiratory group. Here I need to remind you that there are many subdivisions of neurons within these groups. They have different patterns of activity during the respiratory cycle. With a deeper investigation, the ventral respiratory group can be subdivided into, for example, rostral and caudal groups, and also such complexes as the so-called Botzinger complex and pre-Botzinger complex. And the last mentioned is important, so that I'm going to show you this pre-Botzinger complex. As a part of ventral respiratory group, this complex contains neurons that are believed to be the respiratory rhythm generator. They produce automatic, they are rhythm of the automatic activity of the center as a whole, and they operate somehow similarly to the pacemaker of the heart and the sinus node. Then centers located in the pons, pneumotaxic center and the apneustic center, with their opposite influence on the inspiratory neurons. Pneumotaxic center produces its inhibition, decreasing the duration and depth of the inspiration, and the apneustic center stimulates inspiration. The final output goes from the dorsal respiratory group of neurons, and it's regular rhythmical sending impulses down to spinal cord to the motor neurons of the inspiratory muscles. In case of quiet, regular respiration, the expiration goes passively, and it's enough just to relax the inspiratory muscles. But when respiration becomes more active, and expiration process becomes active as well, the expiratory neurons of the ventral respiratory group may start to send impulses also down to the spinal cord to the motor neurons of expiratory muscles, thus stimulating the expiration process. The inspiratory neurons, mainly in the dorsal and partially in the ventral respiratory groups, they send impulses to the spinal cord to the following levels. To the cervical level, in particular C3, C5. These three segments, the ventral horns of these three segments, contain the motor neurons that form the phrenic nerve with their axons. And also impulses reach the thoracic segments from the 1st till 11th for the intercostal nerves that finally stimulate the intercostal muscles external exactly. So, as a result, the diaphragm is stimulated and the external intercostal muscles, which both are muscles for the inspiration. This output of impulses descending from the dorsal respiratory group produces inspiration. Expiratory neurons of the ventral respiratory group, as it was already mentioned, are not active during normal quiet breathing, when the expiration is a passive process. During the more intensive breathing, for example, during exercise, when expiration becomes active, expiratory neurons send impulses that stimulate motor neurons of the expiratory muscles, which include the internal intercostal muscles and abdominal muscles. Neurons of the dorsal respiratory group with inspiratory neurons of the ventral respiratory and with pre-Botzinger complex are responsible for generating the final output that controls breathing. And this activity increases as a rate of impulses increases gradually, promoting inspiration, then disappears, and then it starts again and thus makes the cycles. Let's observe how it looks. The rate of impulses, and this is so-called the inspiratory ramp signal, because look, it goes upward, then decreases, then again, next time it appears, gradually increases and increases, then stops, and then again and again, and constantly it goes like this, with increase of activity corresponding to inspiration and stimulation of the inspiratory muscle occurs at this time, and when activity disappears, expiration goes. Approximately for the quiet resting respiration, the inspiration signal that produces inspiration, REM signal, lasts about 2 seconds, while the pause between two cycles there's about 3 seconds, which is enough for the process of expiration itself, and little interval between expiration and an inspiration. This cycle repeats again and again, and this ramp signal has the advantage that it produces gradual, steady increase in the volume of the lungs. Not a sharp increase, but gradual, steady increase of the volume of inspiration. It can be regulated, as we are going to consider later. Regulation of the ramp signal by the centers of the pons. The pneumotaxic center, as you remember, inhibits the inspiratory neurons by cutting off the ramp signal at a certain point, thus ending the inspiration, starting the process of the expiration. As a result, the volume of the respiration is decreased while the rate increases. Look, for the comparison, first you see normal, quiet respiration signal and how it is changed by the pneumotaxic center. The degree of this changing can be variable, but for example, it cuts off the signal before it reaches normal upper point, and then inspiration becomes shortened, therefore expiration also is not as long as before, and you see the tidal volume decreases while respiration rate becomes higher. And the degree of this change depends on activity of pneumotaxic center. If the pneumotaxic center activity decreases less than usual, so it goes to the opposite side. Volume increases and rate decreases. But we have the opposing center, the apneustic center, that stimulates the inspiratory neurons and thus prolongs inspiration. Then respiration becomes deeper, and volume of respiration increases while the rate decreases. Let's observe this with a blue line. The inspiration goes longer and deeper, therefore, and next one as well. Also observe that angle of velocity of inspiration can be also increased by regulation. Just this picture doesn't show it, but we can regulate not only the duration but the velocity of these changes. Efferent connections. Now, as we consider the structure of the center, we can consider its sensory connections, efferent connections. And they are provided by the chemoreceptors. We already considered before the chemoreceptors, and we know that they include peripheral and central receptors. The peripheral are located in the aortic and carotid bodies, where the baroreceptors are located as well. There are two types of arterial chemoreceptors. One type responds to the oxygen level, PO2, and the activity increases in response to the decrease in PO2. And the other type of receptors, which are more numerous, they respond to CO2 and H+ ions. And in this case, receptors increase the activity when PCO2 level increases and H+ ions level increases. Note that increase in H+ ions concentration is accompanied by a decrease in the pH value. But the receptors do respond to the H+ ions, and pH is just index that shows the level of H+ ions. Let's observe the fibers that pass the impulses from the chemoreceptors to the brain. From aorta and from its aortic bodies, the impulses are sent by efferent sensory nerve, which is called aortic nerve or nervous depressor, but this is a branch of vagus nerve. So it goes to the brain, enters as the vagus. Where carotid sinus with its carotid bodies, they send impulses through the glossopharyngeal nerve. Actually, the branch itself is called sinocarotid or hearing nerve, but then it becomes just a branch of the nerve number 9, glossopharyngeal, and it enters the medulla within this nerve. Vagus and glossopharyngeal nerve. They are a source of the sensory information from chemoreceptors, from periphery, vascular chemoreceptors. Stimuli for peripheral chemoreceptors, let's list again. This is hypoxia, decrease in PO2, partial oxygen pressure, hypercapnia, elevation of the PCO2, partial CO2 pressure, and acidosis, increase in concentration of H+ ions or decrease of pH value. All these stimuli, each separately and all together, produce activation of receptors. Their activity increases from normal level to the higher level, depending on degree of hypoxia, hypercapnia, and acidosis. And they all produce progressively stronger and stronger stimulation of inspiratory neurons in the respiratory center. As a result, lung ventilation increases, thus bringing more oxygen to the lungs and decreasing CO2 and therefore H+ ions level. The central chemoreceptors. Central chemoreceptors are the chemosensitive neurons that are located in the medulla and its ventral surface. These cells increase the activity in response to H+ ions mainly. The main stimulating factor is H+ ion, and with increase, the activity greatly increases. They respond to H+ ions concentration in the cerebrospinal fluid, because these neurons contact with this fluid. H+ ions stimulate chemoreceptors, and as a result, the inspiratory neurons become stimulated stronger than usual, depending on degree of increase in H+ ions. It's important that influence of the central receptors on respiration is much more powerful than influence of the peripheral chemoreceptors. The main stimulus is the H+ ion, but CO2 indirectly may influence as well, because CO2 produces excess of CO2 produces excess of H+ ions. But note that there is no response to oxygen level. There are no central chemoreceptors sensitive to oxygen. Then let's consider how H+ ions may have higher concentration in the cerebrospinal fluid. That's important that H+ ions themselves cannot pass from blood into brain because they don't cross blood-brain barrier. But CO2 easily can pass all the barriers and enter the cerebrospinal fluid. And then CO2 is converted into H+ and HCO3- ions. This reaction is usually performed by carbonic anhydrase, or simply carboanhydrase. Look at this. Beneath you see the capillary. Above, this is cerebrospinal fluid and the brain tissue of medulla oblongata. Now in green you can see these are endothelial cells with a very tight contacts between. They produce the very strong blood-brain barrier or blood-cerebrospinal fluid barrier. But for carbon dioxide, this barrier is not a barrier. CO2 easily passes, and when it enters the cerebrospinal fluid, it becomes combined with water, and carbonic anhydrase easily converts it into carbonic acid. Then carbonic acid dissociates with formation of H+ ions and HCO3- ions. H+ ions then enter the tissue of the brain, and it's sensed by chemosensitive neurons. CO2 is the most important factor stimulating the inspiratory neurons. Let's observe the influence of CO2 and H+ ions or pH on the alveolar ventilation. This figure shows how alveolar ventilation is changed under changes of these two factors. First, this is influence of the pH or H+ concentration on ventilation, and the upper figure shows how much carbon dioxide influences the level of alveolar ventilation. Here it's normal value of the pCO2 for the arterial blood, 40 mm mercury. And with hypercapnia gradually development, from 40 it goes to 50, 60 and so on, alveolar ventilation increases greatly. And if we start from value 1, which is normal basic alveolar ventilation taken as 1, you see, finally it reaches value 11 times higher. So CO2 is a powerful factor that stimulates the ventilation. As for H+ ions and pH as its index, normal value of pH is 7.4 plus minus, and here you see to the right side on a horizontal axis the pH value becomes less and less, so it shows higher concentration of H+ ions, or simply state of acidosis, which becomes deeper and deeper progressively. And you may see at first the influence is not very strong, and alveolar ventilation starts to increase significantly, approximately from 7.2, which is already severe acidosis, and then it increases, but maximal increase does not exceed 4 and some little bit more than 4 times. So influence of the pH is not as strong. And as for changes within norm, let's observe the normal values of pH from 370 or 735 up to 745. This range does not change practically the alveolar ventilation, but CO2 range is very similar. From 40 it may be plus minus 5, 35 millimeters up to 45 millimeters. And normal range, you see, within the normal range the alveolar ventilation changes more than twice. You see, from minimal normal level up to maximal normal level, there is a great change of the alveolar ventilation. It increases seriously, even within normal values of the value of pCO2. You see, more than twice elevation. Little importance of oxygen changes. Let's observe on the following figure. But first, before consideration even of this figure, it's necessary to understand why oxygen changes are not important for the regulation of the lung ventilation. Oxygen, this is the main factor we ventilate the lungs for. And it's from first thing, it's not easy to understand, but we should not wait until oxygen starts to be changed and then it can be stimulating factor. We should prevent changes of oxygen, and more variable factor can be chosen for regulating factor. And exactly CO2 is such a factor that changes quickly, and its change can help in starting the reaction, preventing oxygen decrease in advance. So it's clear why oxygen is not the main factor, while CO2 is really the main. Here you can see on this figure two lines. Let's start first. Both lines show the level of ventilation. Normal ventilation initially is considered to be about 10 liters per minute. This is minute ventilation of the lungs. Really, it's even less on average. And look, in the lower horizontal axis, there is a decline in oxygen from normal value to decreased hypoxia. And you see hypoxia goes, but increase in ventilation begins much later, when oxygen becomes twice less than normal. But in this case, of course, the experiment was done with constant CO2. In most cases, we have hypoxia combined with hypercapnia. But here, only hypoxia was chosen, but CO2 was constant. And you see, oxygen did not change the ventilation until reaching the 2 times less concentration of oxygen, which is rather severe hypoxia. And only then ventilation started to be increased, but not much. Let's observe the opposite situation, when oxygen is not changed, but CO2 is changed. CO2 on the upper, the horizontal axis, initial CO2 is almost zero, and then along this horizontal axis, the CO2 level increases progressively. So this is hypercapnia. And you see, the ventilation starts to grow upward, and finally it reaches the value 8 times higher than initial. Serious growth of ventilation starts with value about 3% of CO2, which is of course high enough. But after this, the line goes up and up very quickly. So hypercapnia produces great increase in lung ventilation. Then now let's consider the interrelationship of the lung ventilation and CO2 blood level. It's very important to understand how lung ventilation influences CO2, and what is even more important, how CO2 influences ventilation back. These influences are bilateral, but they have different mechanisms. The first and very easy thing to understand is influence of the ventilation on the CO2 level. Look, the more we ventilate the lungs, the more fresh air is delivered to the lungs, the more oxygen we bring and more CO2 we remove. Therefore, ventilation increase is accompanied with decrease in CO2 level in both alveolar air and the arterial blood. And oppositely, decreased ventilation produces accumulation of CO2. So it's easy and clear. To observe this, also we can use these figures. Let's see. The first, normal ventilation. Here this minute volume is considered to be about 4 liters. And you see, it produces normal level of the arterial PCO2, about 40 millimeters. Now let's see what happens in case of decreased ventilation. Hypoventilation with 2 times decreased ventilation produces already accumulation of CO2 until reaching the PCO2 level 80, 2 times more than usual. It's a great increase in CO2 level. Then hyperventilation. If we increase 2 times ventilation, you see, ventilation becomes now 2 times more. At the same time, there is a great decrease of CO2 level, and PCO2 falls to 20 millimeters mercury. So it's clear that when accumulation of CO2 occurs with decreased ventilation and loss of CO2 occurs with hypoventilation. But then what happens next? If you imagine it was intentional hypo or hyperventilation for a short time, then what happens to the person after hypo or hyperventilation? Excess of CO2 accumulated due to hypoventilation should strongly stimulate the chemoreceptors, which in turn increase the activity of the inspiratory neurons. And so, let's see. Increased level of CO2 caused by hypoventilation stimulates chemoreceptors more than usual. Therefore, activation of ventilation becomes also high. And this excessive lung ventilation decreases CO2, usually back to its normal level. Or, if it was excessive ventilation of lungs, hyperventilation, with decreased CO2, this decreased CO2 level produces less stimulation of chemoreceptors as compared to normal. And as a result, the ventilation decreases because less of activity of the inspiratory neurons. Decrease in ventilation brings CO2 back to normal level. So here at this slide, in the lower portion, you can see how ventilation directly affects the CO2 level. And above, you can see how CO2 level, not directly through reflex, through receptors, through the center, changes the ventilation level. But now you see the influences of ventilation and CO2 are bilateral influences. Then, due to lung ventilation influence on the CO2 level, you can deduce that there is also an influence on acid-base balance, because CO2 easily forms carbonic acid, which dissociates with formation of H+ ions. Look, according to this equation, CO2 can produce with water carbonic acid, which dissociates to H+ and H3O3-. Actually, the reaction goes bilaterally, goes to both directions. So, but you see there is direct relationship between CO2 and H+. Therefore, bicarbonic anhydrase, it mentioned. Lung ventilation easily changes the acid-base balance. Excessive ventilation decreases CO2 level, but decrease in CO2 is accompanied by decrease in H+ ions concentration. So, in case of hyperventilation, we decrease H+ and therefore increase pH value, or simply we produce alkalosis. With decreased ventilation, there is accumulation of CO2, and this excess of CO2 forms the excess of H+ ions. So there is decrease of pH, or simply acidosis. When the reason of all this alkalosis and acidosis is decreased or increased lung ventilation, we can say that these changes of acid-base balance are respiratory. Respiratory alkalosis and hypoventilation produces respiratory acidosis. But then compensation of acid-base metabolic disturbances can be done by respiration. You see, when change of pH value of H+ ions concentration is not due to respiration but due to some metabolic disturbances. H+ ions influence on the chemoreceptors, which in turn change the ventilation, and therefore respiration may produce a decrease or increase of H+ ions back to norm, or at least closer to norm. Metabolic acidosis, when it's present, not due to respiration, but due to some other reasons of the biochemistry of the body. Let's say the diabetic patient with excessive accumulation of ketone bodies has metabolic acidosis, as ketone bodies are acids, and these acids produced great acidosis, but these acid ions stimulate chemoreceptors and produce hyperventilation as a result. This hyperventilation produces decrease in CO2. Initially, the person has normal CO2, but excessive ventilation decreases CO2, which makes it less than normal. But therefore, less ions of H+ are formed out of this CO2. And so, H+ concentration becomes decreased towards its normal level, and pH becomes higher, closer to normal. Oppositely, if there is metabolic alkalosis due to accumulation of some alkaline products, so decreased H+ ions concentration produces less activation of the chemoreceptors, less than usual. Therefore, stimulation of the inspiratory neurons is less than usual, and as a result, ventilation decreases. There is accumulation of CO2, and this excess of CO2 produces additional H+ ions that compensate the initial alkalosis, and pH becomes less and comes closer to normal, or sometimes returns into normal range of values. These respiratory changes may result in partial or even full compensation of metabolic acid-base disturbances. But this compensation comes from only pH value. The change of CO2 as compared to norm remains. So if there is pH even normal perfectly, but you may see that there is decreased CO2 less than normal. So it shows that there is a compensation, respiratory compensation of the metabolic disorder. And correspondingly, in case of pH slightly alkaline, for example, but at the same time there is hypercapnia, you may suppose that this excessive CO2 is due to decreased ventilation produced by alkalosis initially, and pH can be even fully compensated, but hypercapnia remains. Let's consider the other than chemoreceptors, other types of receptors that also influence the respiration. Maybe first to be mentioned after the chemoreceptors are the lung stretch receptors. These are mechanical receptors, and regardless they are called lung stretch receptors, really they are located not within the lung tissue itself, but in the smooth muscles of the bronchial walls. These mechanical receptors are stretched by inspiration, and impulses are generated proportionally to the degree of stretching. They are sent through vagus fibers to the medullary part of the respiratory center, where these impulses inhibit inspiration and contribute to the beginning of expiration. And all this is referred to as Herring-Breuer's reflex. But it's necessary to mention that lung stretch receptors in the case of normal, quiet respiration are not much activated, and this reflex is not participating in a normal, quiet breathing. Just when respiration becomes deeper with stronger stretching of the lungs, this reflex contributes to the inhibition of inspiration. So it's designed to prevent overstretching of the lungs. And stretching of the lungs goes in parallel with stretching of the bronchial wall and smooth muscles of the bronchial walls as well. So they say approximately about 1.5 liter volume of inspiration is necessary to activate this lung stretch receptor enough to produce stronger influence on the inspiratory neurons and start to contribute to inhibition of inspiration. So under normal conditions and resting respiration, these receptors are not much involved into process. Irritant receptors. These receptors are unusual. They are located in bronchial epithelium. They do not belong to one single class of receptors. They are so-called polymodal. They respond to both mechanical stimuli and chemical. Mechanical, such as the dust, mucus pieces, or you may imagine if the piece of food enters the bronchial wall, then these mechanical particles stimulate these receptors, but as well such chemicals as ammonia, ether, and some others also may stimulate the same irritant receptors. The receptors provide the protective reflexes such as cough and sneeze. So they protect by contribution to the removing of the particle that stimulates the receptor. As for chemicals, of course, they cannot be removed by cough or sneeze, but at least this reaction can occur as well. Also, these receptors may be a cause of the constriction of bronchi, for example, in the asthma disease. And one more type of receptors involved is called Georeceptors. Georeceptors with the first letter because of juxtacapillary. They are located nearby the pulmonary capillaries in alveolar walls. These receptors stimulated by the increase of the alveolar interstitial fluid volume. So, in normal case, when alveolar interstitial fluid volume is normal, these receptors are not involved into regulation of respiration. They do not produce the effects. But when there is an increase of the interstitial fluid volume in the lungs, it makes respiration rate to be increased and tidal volume to be decreased. So the breathing becomes rapid and shallow. Such effects occur when the alveolar interstitial fluid volume increases, and this occurs in case of pulmonary edema and also in case of lung inflammation, pneumonia. Inflammation usually is accompanied to more or less expressed edema as well. So lung edema produces the rapid and shallow breathing. Theoretically, it may be also somehow protective because it increases the loss of water vapors from the surface of mucosa and lung alveolar surface. And so somehow it may contribute to decrease the interstitial fluid volume, but not much effective, of course. The last, influence of the skeletal muscle receptors. We have greatest increase of the respiration in case of great physical activity level. And along with the stimulation from sympathetic system and the others, there is also the influence of the skeletal muscle receptors responsible for this great increase of respiration. It's an important contribution to high intensity of respiration when we have physical activity. When muscles produce regular contractions, they are receptors such as muscle spindles, they are tendon receptors and also receptors located in joints. By producing their feedback to the central nervous system, at the same time stimulate the inspiratory neurons of the brainstem and increase the respiration intensity, increasing the depth and increasing the rate of respiration. This is due to receptors that are called proprioreceptors, the muscle spindles of the muscles, also tendon and joint receptors. But also we have sometimes the increase of lung ventilation even before the exercise is beginning. And in this case, it's believed to be activated by the mechanism of the conditioned reflex, which is learned response, because we have the experience of having necessity in more oxygen and deeper respiration during physical activity. And especially for sportsmen, this reflex operates effectively. And before the start, before any high level of muscle contractions, they already have greater, deeper respiration, which produces additional amount of oxygen before beginning of activity. Let's sum it up in a scheme of the breathing control. First, let's show the respiration center with its different nuclei. Medulla and the main nuclei to produce the output of impulses down. This is inspiratory. This is the dorsal respiratory group with its inspiratory neurons. Expiratory neurons of the ventral respiratory group located ventrally. Pons contains pneumotaxic center and pneustic center. The interconnections of the centers I'm not going to show right now. Let's add the lungs, also the main inspiratory muscle diaphragm, and for example the inspiratory intercostal muscles, just two ribs with these external intercostal muscles. And now you see inspiratory neurons have they send impulses down to the spinal cord to levels C3, C5 to motor neurons in the ventral horns that form the phrenic nerve with their axons. As a result of activation of the phrenic nerve, diaphragm contracts and goes downward, so that stretching of the lungs in vertical direction occurs. Also, impulses reach the spinal cord thoracic segments such as thoracic 1st until the thoracic 11th, and numerous intercostal nerves become stimulated, the motor neurons become stimulated, and the nerves, the axons send impulses to the external intercostal muscles, so that generally mainly upward movement of the ribs occurs, so that the anterior posterior size and even lateral size of the chest cavity increases. As a result of all these muscles contraction, lung stretching occurs. So it's the inspiration process. You remember, ramp signal makes gradually deeper and deeper inspiration, and air is allowed to enter the lungs. Then the ramp signal is over and inspiratory neurons stop sending their impulses downward. As a result, the muscles, skeletal muscles, diaphragm and external intercostal muscles, without impulses become relaxed. This relaxation simply produces normal, quiet expiration. Then it starts again. Respiratory cycle begins and is repeated and repeated. A new ramp signal appears. There is a constant feedback from chemoreceptors, from peripheral and from central. Peripheral go from aortic bodies, and aortic bodies send the impulses through fibers of the vagus nerve into medulla and sinocarotid area. Carotid bodies send the impulses through nerve number 9, glossopharyngeal nerve. All these chemoreceptors respond to the constants of the arterial blood, such as oxygen level. Receptors that respond to oxygen have their normal rate of impulses at normal PO2 level, about 100 millimeters hydrogen. When this level increases, there is a decrease in activity of receptors, and when there is a decrease of PO2 or hypoxia, rate of impulses increases. The much more numerous and much more important for the regulation of respiration are receptors that respond to CO2 and H+ ions. When level of pCO2 is about 40 millimeters mercury ±5 and pH value is about 7.4 ±0.05, it results in normal activity of receptors. But if you remember, for CO2, even within normal range, activity changes. Activity changes so that ventilation changes. But it changes proportionally to the value of pCO2 and concentration of H+ ions. Higher pCO2 level stimulates receptors more, and they generate more impulses per time unit, while decrease in pCO2 produces decrease of activity of these receptors and H+ ions concentration as well. Not shown here in these pictures are the central chemoreceptors located in the ventral surface of medulla, even more ventrally than the expiratory neurons of the ventral respiratory group. Activity of chemoreceptors increase in case of hypoxia and in case of hypercapnia and acidosis, H+ elevation. But normally these receptors respond to normal constants of arterial blood, and remember that in healthy person arterial blood constants remains unchanged regardless of inspiration or expiration, and even regardless of the activity of the muscles. Even physical activity may slightly change the pH and CO2, but not changing the PO2 level. And so under normal conditions, the impulses that are sent constantly from chemoreceptors to the respiratory center, this activity is unchanged and not involved into regular changes of the respiratory cycle phases, inspiration and expiration. Just in case of hypoxia, hypercapnia and acidosis, which for the arterial blood occurs only in pathological cases. In case of deeper respiration, we can add to the scheme the stretch receptors of the bronchial walls, smooth muscles. When stretching degree increases, these receptors produce the activity, and from the smooth muscles of the bronchial wall, impulses are sent through vagus fibers, and these impulses inhibit the inspiratory neurons, so that it prevents excessive stretching of the lung. It becomes combined with the other impulses. It doesn't stop immediately and entirely the activity of inspiratory neurons, just decreases it proportionally to the degree of excessive lung stretching. Also, if you remember, in case of deeper respiration and more active, more intensive, the expiratory neurons start to send their impulses to the spinal cord, to the motor neurons of the expiratory muscles. Influence of the higher brain centers of respiration. What we considered by now, it was the basic structure of the center and its basic activity, but we can influence the respiratory center from cortex, from the limbic system, from hypothalamus. And such factors as emotions, pain, temperature can change respiration. Also, we can intentionally produce excessive ventilation of the lungs, or we can intentionally stop breathing for a certain limited time. So, you see, it means that brainstem respiratory center is influenced by cortex, by the limbic system, by hypothalamus, which have interconnections between them, but finally all these influences the brainstem respiratory center. And it happens when emotions greatly increase the degree of lung ventilation. The pain changes the pattern of respiration. The temperature can influence easily the respiration degree. And also voluntary control. Voluntary control comes from the primary motor cortex, directly to the neurons of the brainstem, respiratory neurons. And we can intentionally stop breathing or hyperventilate intentionally. But more often we do it, actually we do it each day for purposes to talk, because pronunciation of words and pronunciation of phrases requires the expiration process. The airflow should pass through vocal cords. So in order to talk or to sing, we need to produce deep inspiration, and then on the basis of the expiration process we can pronounce all the words we need to say. And so we control our respiration in order to normal communication. As well as during singing, we need to control the respiration process, and so on. Voluntary control is possible. But as for stop of breathing, it cannot be endless, it's limited by build-up, accumulation of the CO2 and H+ ions. And gradually, with this stop of breathing, they become accumulated so much that we cannot withstand and keep from inspiration more. And so at certain moment it stops. Respiration at exercise clearly becomes increased, because with exercise we increase our requirement in energy and oxygen. And we need to increase both lung ventilation and the cardiac output. And also we need to dilate bronchi. And all these changes are directed to meet this requirement in energy and oxygen. First, respiration rate and tidal volume increases, so that it increases the minute ventilation and pure alveolar ventilation. As well, we need to increase perfusion of the lungs. We need to increase the cardiac output, which includes both cardiac heart rate and stroke volume elevation. Blood pressure increases, and also bronchi are dilated due to sympathetic influences on the bronchial smooth muscles. All these changes provide, finally, the constancy of the arterial PO2 and PCO2, with PO2 main constant that remains unchanged in most cases. Venous oxygen level and CO2 level can be changed. Venous PO2 decreases because of great consumption of oxygen, and CO2 increases because of production of CO2 is elevated. Let's observe the increase of ventilation under exercise. Here you see the change of the ventilation of lungs depending on the oxygen consumption level. Oxygen consumption naturally grows in parallel with intensity of the exercise. So it's simply directly proportionally higher exercise and higher oxygen consumption. And you see ventilation also is proportional. There is a direct relationship between oxygen consumption and lung ventilation. These dots represent individual measurements, but generally red line shows the general dependence, general relationship. See, it starts from minimal values of lung ventilation, about 6 liters per minute or so, it can be plus minus, and minimal oxygen consumption in resting state, which is about 200-250 milliliters or 0.2-0.25 liters per minute. And you see, maximally, it can exceed 4 liters per minute. It's a great increase of oxygen consumption. But lung ventilation is increased up to more than 100 liters per minute of the air, and so it provides necessary oxygen. Effects of the exercise. Here you see 4 figures that show the changes of 4 parameters, starting from resting state to physical activity at mean level and up to maximal level of physical activity. First, at the bottom you can see oxygen consumption. It starts to grow, especially strongly. It increases when the medial level of activity becomes changed into maximal. And on the way to maximal change, oxygen consumption grows seriously. Then you can see that the upper portion, the lung ventilation, that grows very strongly with increase in oxygen consumption. It can be seen, it could be seen even in the previous slide. Then arterial pCO2 level. Until certain moment of oxygen consumption grow, it stays the same, constant. But then with serious elevation of the activity and high level of oxygen consumption, arterial pCO2, due to hyperventilation, excessive lung ventilation, can be even decreased. But what remains steady, unchanged, constant, this is arterial partial oxygen pressure. This is unchanged even in case of very heavy exercise. So it does not change. And that's all I wanted to explain about the regulation of respiration. Thank you for attention.